Today we're taking you step by step through one of the most common orthopedic trauma surgeries, open reduction and internal fixation of an ankle fracture. We'll start with the life and limb saving part that many videos skip, and then we'll walk through the entire fixation from skin to skin. Before we ever think about plates and screws, every open fracture gets urgent irrigation and debridement. This is not optional, it is the single most important step in preventing infection and osteomyelitis. We use 6 to 9 liters of sterile saline and gently pulse it to wash the bacteria out. We also carefully remove any dead or badly damaged tissue. This single step is the biggest factor in preventing a serious infection later. If we get this right, the rest of the surgery becomes much safer. Prior to making incisions, we use an intraoperative X-ray imaging device called a C-arm to mark out the fracture sites. This ensures that we make our cuts in the ideal locations for fixation of the bone. Using a scalpel, we make a curvilinear incision on the inside aspect of the ankle. Then, with tissue scissors and forceps, we begin the dissection down to bone. The goal of the dissection is to protect the vessels, nerves, and tissues as much as possible, while also getting adequate exposure of the fracture site so we can properly reduce it back in place. If we come across bleeding from the blood vessels during the procedure, we use the electrocautery knife to stop the bleeding. Right here, Dr. Staples is grabbing a bleeding vessel with the forceps, and I use the cautery knife to directly stop it from bleeding more. During this dissection, we use a self-retaining device to keep the skin edges and tissues retracted out of the way. We also use an elevator tool to bluntly continue the dissection. This elevator tool is helpful to remove adherent tissue from the fractured bone fragments. If the fracture site is not cleared from tissue and debris, the final bone alignment will not be anatomic and the patient will not heal properly. Now that the fracture site is appropriately exposed, we flush the joint with sterile saline to wash out any further debris that would prevent us from reducing the fracture to its proper alignment. Using a tool called a dental pick, Dr. Staples provisionally holds the fractured segments together and then inserts a wire to secure the positioning. With the fracture held in anatomic alignment with the wire, we can now insert hardware to fix the bones definitively. There are various methods to fix this part of the ankle. Sometimes a plate is needed for robust fixation. Sometimes we drill directly over the wire and afterwards place a cannulated screw over the same wire. Other times, like shown here, we drill just beside the wire and place screws through the fracture and secure it next to the wire. A patient's bone quality, skin quality, and fracture pattern will determine which method is most appropriate. Once we drill, we use a depth gauge to measure the length of the hole so that we can insert the correctly sized screw. The screw is then inserted in that previously drilled hole. While one screw can theoretically be enough to hold the fracture site together, 2 screws is always better. These 2 points of fixation create a powerful construct that hold the site secure during the healing process. Once this first screw is in place, we repeat the steps just performed. We drill, use the depth gauge to measure length, and insert the second screw. With both screws in place, we can remove the wire as the fracture is stable. To further confirm the stability of the bones, we use the dental pick again to assess for any movement. We now move to the other side of the ankle to address the fibula fracture. Using our marked outlines from the beginning of surgery, we make an incision with the scalpel. Similar to the process we just performed on the other side, we use tissue scissors, forceps, elevators, and the electrocautery knife to complete the dissection down to bone. Again, the goal with the dissection is to expose the fracture site while also protecting the tissues, nerves, and vessels. Once the fracture is adequately exposed, we can position a plate directly on the bone to span the fractured site and place screws to hold it all together. Often, it is needed for clamps and wires to get the fracture back into proper alignment prior to the plate being utilized. There are plates that come in different lengths and sizes. Given the fracture pattern, fracture location, and the patient's bone quality, we can choose from a number of plate options to ensure that the fracture gets the proper fixation and heals correctly. If we like the reduction of our fracture and the placement of the plate, we use a drill directly through pre-engineered holes in the plate. We use a depth gauge to measure the length and place screws through the plate and into the holes in the bone. The plate we used for this surgery was considerably long as we needed multiple points of fixation above the fracture and multiple points below the fracture. Having adequate fixation above and below the fracture site ensures that the fracture has enough stability throughout the fixation to heal without complication. Once the plate is secured with a few points of fixation, we can then effectively repeat the process of drilling and inserting screws until all the needed hardware is implanted. Right now, we are working on the shaft of the bone above the level of the fracture. Once this section is finished, we move down the ankle and place the fixation on the lower side of the fracture to complete this phase of surgery. The process of drilling, measuring, and inserting screws moves quickly for this segment as the fracture is already reduced in great alignment and the plate is already secured above. After the hardware is implanted, we move to the next phase of surgery, which is closing up the incisions. We begin with a strong dissolvable suture to bring the deep layers of tissue together. The closing of the wounds is meticulous as we want to minimize infection risks at all costs. Once the deep layer of suturing is complete, we move to the most superficial skin layer. We use a nylon stitch to finish the closing of the incisions. These sutures are not dissolvable and will need to be removed in 2 to 3 weeks. As we review the intraoperative images of an ankle fracture surgery, we see the amazing process of bone fixation. The goal of surgery is to restore bone stability and give patients the best chance at full function and recovery.